following is a production of West Virginia Public Broadcasting.
Major funding for Doctors on Call is provided by a grant from the Milan Charitable Foundation. Other funding is provided by the Health Plan, a health maintenance organization serving West Virginia and Ohio since 1979. By the Center for Organ Recovery and Education, supporting Volunteers for Life through organ, tissue, and corneal donation. By Health South Rehabilitation Hospital, serving your rehabilitation needs in Morgantown and Fairmont. And by the faculty and staff of the Robert C. Byrd Health Sciences Center of West Virginia University.
Welcome to Doctors on Call. Tonight's topic, women's health. Two experts are here to answer your questions. Now here's your host, Dr. Bill Ramsey.
Good evening. From puberty to pregnancy, menopause to old age, a woman's body is constantly changing. So are her health needs. What form of birth control is best for you? Should you consider estrogen replacement therapy after menopause? What can you do to prevent breast cancer? We'll get answers to those questions and more tonight from our two guests. Dr. Maureen Hashmi, an obstetrician and gynecologist at WVU's Cheat Lake Physicians, whose special interests include treating endometriosis, and Dr. Charles Hochberg, also an obstetrician and gynecologist at WVU, whose special interests include menopause changes and high-risk pregnancy. If you'd like to ask our guests a question, give us a call. Our phone lines are open now. Well, Maureen, let's start. Obviously, this is on West Virginia Public Television in West Virginia, but West Virginia women are not the healthiest in the country, are they?
Unfortunately, Bill, they're not. West Virginia women actually lead the country in terms of obesity, hypertension, diabetes, hyperlipidemia, and even smoking.
So we got a lot of issues there, and a lot of those are preventable, right? Or at least there's some things that can be done about them.
Absolutely, and I think that's really the point of annual examinations, when you meet with your clinician to identify what your family history is, your risk factors, and to make a long-term as well as a short-term plan.
So we'll talk some more about that. Charlie, we've made some improvements in a lot of areas. How much of a problem now is teen pregnancy?
Well, teenage pregnancy is a problem throughout the country, and it's certainly here in West Virginia as well, especially in the rural areas where contraception may be an issue and young women reaching someone to advise them on how to prevent an unwanted pregnancy. And then the teenage pregnant woman presents two problems. One to herself, of course. Hypertensive disorders in pregnancy is much more common in young women than it is in women in their 20s and 30s. And then the special danger to the fetus if the mother does develop high blood pressure, has poor nutritional intake. We have a much higher rate of small for gestational age babies or babies that just don't grow well in utero to these young women. So it's a double-edged sword, and efforts are made, of course, to try to prevent that.
Maureen, when we were talking just a second ago, it was about screening. So let's just start, since it's women's health. What are some basic screening things that all women should be doing, and what's kind of the time sequence for those?
Your screening actually is dependent on your age group.
Okay.
So there's different screening tools that we use at different ages. And in general, at your gynecologic visit, it should be much more than just a pap smear. So we're assessing whether or not you're doing your self-breast exams. Do you require a lipid screening? Are you in the age category to start to begin screening for that? Mammograms. We generally begin mammograms between about 35 and 40, and then every other year, approximately after 40, and then yearly after 50. Colonoscopies. If you have a family history, that tends to be a decade earlier. If not, then at 50, we recommend a baseline colonoscopy. So it's not only figuring out what the patient's at risk for, but implementing those tools to help diagnose diseases earlier.
And when should young females have their first a pap smear or pelvic exam? Is there a general age for that?
Yeah, actually the recommendations have recently changed for pap smears. So it used to be age 18 or when a patient becomes sexually active, and now the recommendations are within 3 years of becoming sexually active that you should have a pap smear. Now, that doesn't mean that you shouldn't come in for your first annual exam before that time. I think it's a good opportunity to, again, identify risk factors and talk about abstinence, contraception, STD risks, and all those other issues that go along with the risks of being a teen.
Okay, let's go right to our first call. We're going to talk with Mary in Calhoun County. Hi, Mary.
Hi there.
Do you have a question for us?
I do. Had a hysterectomy 7 years ago, and I have hormonal imbalance, although I'm on identical hormones called bioidentical. My question to you is, I have a disconnected, lightheaded feeling that I experience most every day, and I've had blood work, I've had tests, I've been to several doctors, and wondering if you could possibly answer or direct me in a way, to know how to figure this out, to what the cause of this might be.
How old are you, Mary?
I'm 55.
Okay. Either one of you want
Just a
to
question, Mary. You had your ovaries removed when you had your uterus removed, or your ovaries still inside?
Everything's been removed.
Okay. Well, just
one
to
of you?
say that the lightheadedness and the disconnect, we tend to believe that everything is related to your hormones. And in fact, as a woman of 55, you have other organ systems that may very well be giving you that. You should be seen by a physician to make sure that your blood pressure is adequate, that your thyroid function is adequate, that you're getting enough circulation to your head, for example. The carotid artery should be palpated or listened to. So there's a lot of reasons for having a disconnect or a hollow sensation in your head that may not be hormonal. We always have a tendency of chalking everything up to your hormones. As far as you being on replacement therapy and your blood studies being measured, I hope it's blood. There's some people that do other things like saliva testing, which really has not been shown to be beneficial. But if you've had blood testing and your doctor says your hormone levels have been readjusted into what would be a normal range for a 55-year-old woman, then I'd ask you to try to make sure there's nothing else going on that may be giving you those sensations.
I agree with Charlie. I think you have to rule out that there is not some other underlying disorder that could be causing this. But it is interesting that a lot of patients do complain of this perimenopausal kind of mood disorder where they feel like things are fuzzy. They can't quite concentrate as well. And in fact, studies have shown that women who are placed on estrogen replacement therapy, actually by transcranial Doppler studies, have shown more blood flow to the brain. So there is some people do complain of feeling fuzzy, a disconnect, inability to concentrate, and that can be related to hormones. But I agree with Charlie that first you have to rule out the most likely things first, and then go back to whether or not it's the hormones.
You mentioned estrogen replacement therapy. There's been some swing in that, or misconception maybe out there about that. We were talking about that before the show. You want to comment about that just briefly?
What we were talking about previously is in 2002, the WHI, or Women's Health Initiative, was a large study that came to light that really changed a lot of how we practiced in terms of prescribing hormone replacement therapy. The problem with that study is that many women stopped acutely their hormones, and subsequently about 40% of those women went back on hormones because of symptoms. However, the study was conducted on women in the average age group of about 62, and the average age of menopause is about 50 to 51, and typically the women we put on hormones are women in their late 40s to early 50s. So I'm not sure that the inferences that we've made from this study are really reflective of the population we mainly deal with.
Do you have any comments?
Yeah, the Women's Health Initiative would show that there might be a slightly increased risk in heart attack and an increased risk in breast cancer was not as good a study as we wish we had done. The study was sponsored by pharmaceutical companies originally, and they chose the age of 62 to 63 as the mean age, which was well past what we normally start hormonal therapy on. In observational studies, it shows that women who started hormonal therapy, especially estrogen, with the onset of menopause or in transition when they're in their late 40s or early 50s, may in fact have some protection to these diseases. But unfortunately, once you already have disease and you start hormones, it showed that it's not going to help you any.
So it shows you that nothing's exactly perfect there at all. Let's go to another call. Let's go to Cabell County and talk with Elaine. Elaine, go ahead with your question.
Thank you, doctor. I'm 60 years old, and I had a complete hysterectomy in my late 40s. And I, for a couple of years now, have been able to, well, more or less lactate out of my left breast. And I get a yearly mammogram, and the doctors don't seem concerned about it, but my breast is sore a lot, and how in the world could I be lactating? I mean, I'm on the strongest dose of HRT, and the doctor cut it way back right after my hysterectomy, and I developed a rectocele and cystocele. So, I mean, how could I be lactating at my age?
Okay.
So my question would be, are you spontaneously lactating, or is it something that when you press on the breast, you get discharge?
No, it's when I squeeze my breast and it comes out of my nipple, because my breast is sore like when I was breastfeeding my babies. It's sore like that.
Right.
So I squeeze and the well, I call it milk, comes out.
Understood. Okay.
So not actually a completely uncommon complaint. I think the main thing is, one, you have to rule out, are there any other medications that the patient is on that can cause that? Because there are a whole host of other medications that actually can cause leaking from the breast. Now, things that would be worrisome were if she had a mass, if she had bloody discharge. I would be concerned about that. And again, what can actually be done by the clinician is they can actually express that discharge and look on a slide under the microscope and examine those cells, and you can even send it off for cytology.
So again, it does warrant some further investigation to make sure that it is what she says it's lactating. But any discharge like that at that age certainly needs to be investigated.
Anything from the breast needs to be fully evaluated, but not all the time do we actually find a cause that's pathologic.
That's especially true in someone in their 60s. You're really not lactating, and if there was some systemic effect that's doing it, some systemic drug, you'd expect it to be bilateral. This is just one breast that's doing it, and that's a little bit unusual. And I think it bears further observation. You should not only have a mammogram to that breast, but you might even need an MRI done on that breast to look for something that may be small, not seen by mammography. The other thing that could be done is a galactogram, which is a little tube that's placed down the nipple and dye is injected, and look for the ducts, because this may be a ductal problem, to see if you have a papilloma or a little cyst or a little, even a benign growth in the duct that's producing this fluid. So mammogram is a wonderful tool for screening, and we do special imaging with mammography, but there are other diagnostic tools that might be considered at this time, especially if there's a large amount of fluid coming from one breast.
Right. Well, our topic is women's health, and our phone lines are open, so give us a call. The number's on your screen there. Charlie, let's talk for a minute about osteoporosis as we go in the menopause and the osteoporosis issue that comes about in women. That's very important.
It's very important. Interesting facts, women over the age of 60 that fall and break a hip, 20 to 25% of them will be dead within 1 year of breaking the hip. This is a major killer in older women, so it is not just a bone disease, it's a bone disease with a huge mortality.
And just so we're clarified, osteoporosis, for those viewers that don't know, is decreased calcium in the bone,
right,
which makes it more brittle.
Right, the bone actually loses its bridges. The best analogy is if you have like a footstool that you're sitting on, like a bar stool. If you look at it, it has 4 legs, and it's relatively sturdy. But if you put 4 more horizontal bars between the 4 legs, then the stool is really strong. And that's what happens to your bone. What happens to your bone is you start to lose the bridges within the bone itself, and it loses its strength. Now, way back when I was a medical student, osteoporosis took up absolutely no room in my textbooks. And the reason for that is that the average age of women at the turn of the 20th century, the life expectancy was about age 50. And menopause occurred about age 50. So women lived to 50, and then they died. So they really didn't have many years after menopause.
They didn't get osteoporosis.
They didn't get osteoporosis. Now, if a woman lives to age 50, she has a life expectancy of 80, which means she lives 30 years without her estrogen. So we are seeing the diseases that occur in women who get older. And that's a major issue is osteoporosis now.
And there's been some slight changes in how that's looked at, is that right?
And I think the other thing that we need to think about, too, when we talk about osteoporosis is we see it as a disease of postmenopausal women, but truly the prevention starts in your young adulthood. It's exercising, it's calcium, it's drinking milk, which, we're in this generation that has the milk substitution syndrome where they're using Diet Coke in places of milk. And so, when you see people for their annual exams, we really need to be talking to them about milk consumption and calcium and weight-bearing exercise. It's what you are at 30 that's probably going to determine whether or not you have a fracture or get osteoporosis, not really what you are at 50. It starts much earlier. So those are the things I think when we have our annual exams we need to really be teasing out from patients.
Okay, we've got another call. Let's go down in the Huntington area, down to Cabell County, and talk with B. Good evening, B.
Hello. I would like to ask, at what age should a woman stop all hormones? I'm 78 years old. Should you continue hormone therapy when you're older?
I'll take that.
Okay, you got it, Charlie.
The recommendation in the American College of OBGYN now is that you use hormones as long as you need it for vasomotor changes. There's going to be a very small percentage of women in your age group.
Vasomotor changes are?
Hot flashes.
Hot flashes.
So there's going to be a very small number of patients in your age group that may still be having hot flashes. If you are, then I think that you ought to go over this with your doctor, and you may be a candidate for continued therapy. However, if you are not having vasomotor changes or hot flashes or major sleep disturbances that are due to estrogen withdrawal, you probably should not be on the medication. I will say this, there's one organ that may need estrogens forever, and that is the vagina. So in patients that may not be on oral estrogens, there still is a place for estrogen therapy in areas in which there's nothing else that substitutes, like estrogen, for making the vagina pliable and still accommodating. Patients, therefore, may be on it forever, but not necessarily orally.
Okay, anything you want to add?
Well, just that when we talk to patients every year at their annual exam about whether they want to continue their HRT or not, one of the things I tell them is that if they are going to wean, they may not want to wean in the summer. There's two things that provoke hot flashes, and one is heat and the other is anxiety. So when you're in the middle of July, it may not be the best time to wean your estrogen. So sometimes during the winter months, we say, go ahead and have a trial off, see how you do. If you don't have symptoms, great. You don't need to have it anymore. If you do, then it proves to yourself that you require the drug.
So the advice to be, probably discuss with your physician, analyze what symptoms you're actually having, and if it is time to go off of that, it sounds like you want to go off of that kind of slowly. So good advice for B. Maureen, let's talk change topics a little. Let's talk about, I think, an amazing, another anti-cancer, if you will, vaccine. We talked about that with liver many years ago, but it's been a few years, but the HPV vaccine, which is now fairly significantly recommended, which you want to talk about what it is and why it's important?
Sure. The HPV vaccine, or Gardasil, is a vaccine that the CDC is now recommending for all women, girls from ages 9 to 26. It's what we call a quadrivalent vaccine, which means that it is protecting against 4 different types of HPV, although there's
that's a virus.
It's a virus. HPV is human papillomavirus, and there's over 150 strains of HPV. However, we have 4 main strains that seem to cause the most problems. 2, which cause 90% of genital warts, and then 2 that cause 70% of cervical cancers. Being that a woman in her lifetime has about a 50% risk of actually exposure to the virus, this is a public health concern. We're seeing about 13,000 new cases of cervical cancer a year and about 3,600 deaths. So this is one step towards a public health concern. I think it's a step in the right direction. I think until we actually vaccinate our boys, we won't resolve completely the issue, but I think it's a step in the right direction.
Because that can be carried by the male as well, right?
It's a sexually transmitted virus.
And so the vaccine prevents the virus, which therefore can prevent the cancer.
So right, it's going to prevent the acquisition. If the male has the virus, but the female has had the vaccine, it's going to prevent the acquisition of that virus, and therefore precancerous changes on the cervix as well as cervical cancer.
And that's the reason also that we're starting to see that. And what is the recommendation from when? It's best to get that before they're sexually active.
The idea of the vaccine is that you vaccinate your girls before they're actually sexually active so that they haven't had exposure to the virus. Now, there has been studies showing that you do benefit even if you have had exposure to the virus. You may not have all 4 strains. So if you have the virus and you get vaccinated, it still may protect you against some of the other strains.
Great. Let's take a call from Monongalia County. Julia. Hi, Julia.
Hello.
Do you have a question for us tonight?
Yes, I do. Actually, I had 2 questions. One is the value or not of the herbal hormones, that is the patches or the creams and so forth, and the natural hormone. And the other was one doctor had spoken to the fact that hormones are of no value if a woman is not sexually active, And I was wondering, what about the value of mood enhancement or a sense of well-being? How does hormones play into this?
Two questions. I think the second one, maybe she misunderstood what was said. I don't think either of you stated that.
No. There is a place for hormones. I was trying to make the point that there is a place, even in the advanced aged female, but it's usually local. It doesn't necessarily mean systemic estrogen is indicated, but local estrogen might be indicated if they still, for example, are sexually active or have some difficulty with urinary incontinence, especially dribbling. Estrogen in the vagina may decrease some of those symptoms. In regard to herbal estrogens, well, we're going to lay it on them, right, Maureen? The fact is there's never been an article that has demonstrated that herbal estrogen in any way is any better than pharmaceutical estrogens. In fact, there's some serious concerns about whether being even biologically active. For example, progesterone on the skin is almost useless. There's almost no absorption to that. It's a plant source progestogen for the most part, and you don't have the enzyme to even absorb it. If you're a carrot, you might get some progesterone benefit, but other than that, not really. So I'm afraid it's turned into a great industry now. Estrogen has been shown to be beneficial, but there's no difference or no benefit over naturally occurring estrogens than there is in pharmaceutical estrogens.
Just to comment along that same line, one of the things that I don't think patients actually know is that these natural or herbal or bioidentical even hormones that they think are more natural are not regulated by the FDA. They're considered supplements. So there's no quality control on these medications as there are for other medications that go through the FDA. So in terms of dosing, we really don't know what the dose people are getting and whether or not it's effective or not because this system is not in place. And that's one of the drawbacks with taking those medications for the physician to try to regulate something that there is no real recommendations on.
Right. And 17-beta estradiol, which is the most common used estrogen now, which is pharmaceutical, comes from a plant. So it is a plant source. It's just we don't make a big deal about it. They're all plant sources.
Well, we've got another call. Let's go to Kanawha County and talk with Lynn. Hello, Lynn.
Hi.
How are you tonight?
Oh, I'm doing good, thanks.
You have a question for us?
Well, yes, I'm like a 7-year breast cancer survivor. And prior to that, 6 months before I was diagnosed with breast cancer, I had a complete hysterectomy. And I also have been diagnosed with osteoporosis. And that plus have no libido. And I'm just wondering if there is any estrogen that I can take or anything that would help with the osteoporosis and the low libido.
How old are you, Lynn?
57.
And was your cancer an estrogen or progesterone positive cancer?
It was estrogen positive.
Yeah. So that's the difficulty. When you have premenopausal breast cancer that is hormonally responsive, then no one's really going to recommend that you take a hormone because that's thought to be part of the biologically active part of the cancer. So that's the difficult part. Now, in terms of the osteoporosis, I'm not sure if this caller's ever been discussed with using Evista, which has been shown to help prevent and treat osteoporosis, yet also decrease the breast cancer risk. So that would be a logical discussion that she should have with her provider, because there are bisphosphonates, which is what we typically use for osteoporosis. However, this drug has been shown to decrease breast cancer risk.
And then her other thing, she also says that the libido thing is a little tough. And any suggestions on that?
If I had the answer to that, I'd be a Nobel Prize winner.
Yeah,
the fact is, libido has always been a difficult issue. Let me just sum it up. Libido is sort of like a circle. If you put libido in the middle of a circle and you put a bunch of arrows coming in, with each arrow representing some other part of your lifestyle. We tend to see decrease in libido without your medical problems. And much of it is due to the fact that we have self-image problems as we get older. I don't know if your breast cancer was treated surgically, and if so, whether it affected your own image of yourself, which is always a problem. Then, of course, as a sexual partner gets a bit older, I mean, I come out of the shower and I look at myself and I'm not thrilled with what I see myself. And that's going to affect my libido as well as my partner's libido. So libido is a big issue. It does have some hormonal effects. But it isn't strictly hormonal. There are a lot of other issues like
So
image.
in the case of Lynn, she has some other options to look at, in particularly in the osteoporosis area.
She does.
And in working through those
And
things.
I think what she also needs to know is that women's libido does decrease with menopause. As you lose your testosterone, we lose at least 50% of that at menopause. So it's a natural part of the journey, unfortunately. Like Charlie said, there's other things that may contribute to it, but it naturally does go down for women across the board.
I'm going to give each of you about 5 seconds for improve women's health, the one thing important for them to do. One thing.
Stop smoking and go to the doctor.
Annual
Okay, and you get that, too.
examinations.
Annual examinations. We're out of time. We've been talking about women's health with Dr. Maureen Hashmi and Dr. Charlie Hochberg. Thank you both very much for being with us tonight. If you'd like more information, see your family doctor or visit our website at wvuhealth.com. For Doctors on Call, I'm Dr. Bill Ramsey. Good night and good health.
Join us again next week for another edition of Doctors on Call. Our topic will be sports medicine.
Major funding for Doctors on Call is provided by a grant from the Milan Charitable Foundation. Other funding is provided by the Health Plan, a health maintenance organization serving West Virginia and Ohio since 1979. By the Center for Organ Recovery and Education, supporting Volunteers for Life through organ, tissue, and corneal donation. By Health South Rehabilitation Hospital, serving your rehabilitation needs in Morgantown and Fairmont. And by the faculty and staff of the Robert C. Byrd Health Sciences Center of West Virginia University.
This has been a production of West Virginia Public Broadcasting.